It's actually a complicated decision about when to treat a patient with non-metastatic castration-resistant prostate cancer, because some of them can go a long time on no treatment and have a very good prognosis. And others, in the other end of the spectrum, may actually have a fair amount of disease that is not forming three-dimensional tumors that show up on scans. They may have bone marrow-based disease, for example. Of course, in prostate cancer, the best marker of disease pace is change in PSA. So generally what I do is if a patient has a PSA doubling time that's less than 9 months or around 9 months or less, I will watch them quite vigilantly. We do use and have used over the years many secondary hormonal therapies in this space, simply with the goal of reducing PSA, because we've felt generally that reducing PSA is a good thing in that it prevents metastases from forming. So I look at the pace of the PSA, I scan frequently, and of course try to read the patient's anxiety about the situation and look at where prostate cancer is in the context of their other medical illnesses, if there are any. So for patients who become castration resistant, until quite recently, the only treatment that patients were typically on would have been a therapy like an Gnrh agonist or an Gnrh antagonist, and perhaps an oral androgen receptor antagonist such as bicalutamide. Now many patients are receiving abiraterone as part of their initial androgen deprivation therapy, and so many patients who are coming into castration resistance at this time have received abiraterone. I actually should say not necessarily at this time, but in the future will have received abiraterone. And similarly, many patients are receiving docetaxel in the context of castration-sensitive metastatic disease. Now, many of those patients, when they progress to CRPC, will have metastatic CRPC, not non-metastatic CRPC.
The current treatments available for non-metastatic castration-resistant prostate cancer are pretty antiquated. We have ketoconazole that basically turns off the adrenal glands and reduces one source of androgens, but it's never been approved in prostate cancer. It's an old-fashioned fungal drug, antifungal medication. We also have estrogens, so we can give those by patch or by mouth, but they can cause blood clots and also cause breast enlargement and tenderness, so patients don't really like them. We also have first-generation androgen receptor antagonists, such as bicalutamide, flutamide, and nilutamide, which all can, the cancer can be resistant to those when it upregulates its androgen receptors. Sometimes we double up on some of those agents or rotate through them trying to get some effect, but there's no real data saying that they help people live longer, that they increase the time to metastatic disease. And so in that situation, we're trying to lower the PSA, but not very successfully. So the rationale of using AR-targeted therapy is to block the actions of the remaining androgens. I say androgens meaning male hormones. When we turn off the testicles, we're only blocking about 90% of androgens, but the cancer itself can produce some, as can the adrenal glands. So the rationale is to block the actions of those androgens by making them unable to bind to the androgen receptor. I use these types of agents all the time, from the first generation ones that I described, such as bicalutamide, to the second generation androgen receptor antagonists that are currently only approved for metastatic prostate cancer. Gnrh agonists are those drugs that don't have the testosterone flare. So most of what we use, such as Lupron, Eligard, Zoladex, are LHRH or GnRH agonists. And they cause an initial flare in the testosterone before they block it. There's some thought that maybe antagonists are better than agonists, although there's not conclusive data on that. So mostly when we use the antagonists, we're using it in the upfront setting in newly diagnosed metastatic prostate cancer. The unmet needs in non-metastatic castration-resistant prostate cancer are huge. There are no therapies in that space currently that have been shown to improve survival or decrease the risk of metastatic disease. So currently we have some old-fashioned drugs that we play with in this space, such as the ketoconazole or doubling up the bicalutamide or trying estrogens. But all of those have very scant data and we don't know that they're doing the patient any good. Prostate cancer becomes symptomatic when it's metastatic. Prior to that, in the non-metastatic space, we're only treating the PSA, which is a lab result. So anything we can do to delay metastatic disease could be beneficial to the patient, particularly because the metastases go to the bones, which can be quite painful.
Well, the unmet need in non-metastatic prostate cancer for the current time is a therapy that can prevent metastases. I mean, we generally think that preventing metastasis is a good thing, and there are papers that show that delays in metastasis delay death from the disease or improve survival. So that's kind of the goal of therapy. So the unmet need would be to find a therapy with a very good safety profile, one where we can administer it without significant side effects and can prevent metastasis from forming.